Neonatal resuscitation, NRP. All newborns require active stimulation and supportive measures when they are delivered into the world. In the vast majority of cases, those supportive measures are limited to airway clearing, drying and warming, and active stimulation to promote breathing, crying, and circulation. In a few cases, active resuscitation may be required. Neonatal resuscitation procedures are indicated in infants less than 30 days of age who are in severe cardiorespiratory arrest. Equipment required for these procedures include warming and drying towels and a hat to create a birthing bed, suction, clamps or forceps for the umbilical cord, a scalpel to cut the cord, an infant BVM with filter, a stethoscope to auscultate for apical heart rates, and a biohazard sharps container. Prepare the equipment in advance, including a birthing bed from warm towels if available. As the infant is fully delivered, clamp and cut the cord at least a hand's width from the infant's abdomen and receive the infant into the towels. The first 30 seconds of neonatal resuscitation includes an immediate assessment for the presence or absence of meconium in the airway, breathing status, skin tone and color, and the determination of the gestational age of the infant. Simultaneously, clear and/or suction the airway, while your partner can actively dry, warm, and stimulate the infant to prevent heat loss, consider the environment the babe has just come from, and to stimulate breathing. Note how the bulb suction is squeezed prior to insertion, then released to create the suction, and that the mouth is cleared before the nostrils. After 30 seconds, move the neonate to fresh, dry towels and reassess for breathing effort, heart rate, and color. If the neonate is breathing and pink, continue with supportive care only for the infant and the mum. If the neonate's breathing is inadequate, gasping or agonal, or the heart rate is less than 100 beats per minute, initiate positive pressure ventilation with room air using a bag valve mask with filter and mask at a rate of 40 breaths per minute with just enough air to make the chest rise. In neonates, heart rates are best assessed by auscultation and tapping out the rate while your partner calculates the beats per minute. This also alerts your partner to next steps if the rate is audibly slow. Continue with positive pressure ventilations for 30 seconds. Most neonates that require positive pressure ventilations will respond quickly and the heart rate will rise accordingly. This action stimulates the physiological mechanisms that enhances the neonate's respiratory response and effort. After 30 seconds, reassess the heart rate by auscultation. If the neonate is breathing adequately on his or her own and the skin color is good, continue with supportive care for the babe and mum. If the heart rate is above 60 beats per minute, but less than 100, continue with positive pressure ventilations and add supplemental oxygen at 100% FiO2. If the heart rate is below 60, initiate 2 rescuer CPR using the 2-thumb technique shown here for another 30 seconds. Breaths are interposed between chest compressions once every 3 compressions, and the rate of compression is fast at least 100 compressions per minute. After another 30 seconds, reassess the apical heart rate. As above, if the neonate has improved and is breathing adequately on his or her own, continue with supportive care. If the heart rate is above 60 and below 100, continue with positive pressure ventilations. If the heart rate has not improved above 60 beats per minute, primary care paramedics should continue with CPR and transport, while advanced care paramedics should continue with CPR, endotracheal intubation, and the administration of epinephrine 1 in 10,000 every 4 minutes, and then transport. Continue to reassess the neonate every 30 seconds.